My name is Phillip G. from the University of Texas MD Anderson Cancer Center. I'm here to talk to you guys about how to perform the perfect EMR for colorectal polyps. Here are my relevant disclosures. So in this lecture, we are going to discuss how to perform the perfect EMR. We'll talk about all the different aspects of EMR, from lesion selection to resection strategy to resection technique to post-resection considerations and how to avoid common pitfalls. So to give you guys a bit of a background, endoscopic resection is standard of care for almost all superficial GI lesions. And as far as my own background, I'm an advanced endoscopist at MD Anderson Cancer Center, and it may surprise a lot of you that I have a very high volume colorectal ESD practice with excellent resection outcomes. And so I'm comfortable considering ESD in most cases, and so you may kind of wonder, well, why should I still consider EMR in 2024? And by extension of that, why am I giving you guys a lecture about how to perform the perfect EMR in 2024? Well, we should talk about EMR because ESD is not always successful. This is probably the most classic colorectal ESD article ever published, and this was in GIE in 2010. Yutaka Saito from the Japanese National Cancer Center published a series of 1,111 colorectal ESDs. My suspicion is that he wanted to prove that he was number one, and number one by publishing 1,111 cases. And he showed an impressive 88% en bloc resection rate. Wait a minute, 88% en bloc resection rate. You realize that that means that there's a 12% piecemeal resection rate. How about North America? So Peter Dragunov, Hiro Aihara, and colleagues published the multi-center North American ESD study. 211 colorectal ESD cases, 86% en bloc resection rate. Wait a minute, that means there's a 14% EMR rate. I talked about my own experience at DDW last year, and this was a learning curve study, and I talked about 231 colorectal ESDs, and I freely admitted that I converted 15% to hybrid ESD. In other words, I started off as an ESD, and for whatever reason, we had to finish off with a snare. And so why does ESD fail? So ESD can be unsuccessful for a lot of different reasons that we don't like to admit. So difficult anatomy, scope could be unstable, bowel prep could be poor, it might be too big, might be too hard, might be too fibrotic, patient might be too sick, it might be too late in the day, you might be too tired, you just don't want to admit it. We all just say, maybe it's just not worth the risk. And then there's expectations versus reality. So an outside referral came in for an EMR, or for an ESD rather. So 6 to 7 centimeter ascending colon polyp. The patient lives out of state and has to go home the next day. They have all sorts of medical comorbidities, and the patient's spouse is a physician and actually asks you about ESD. How's that for a red flag? Guess what? This is reality. So ESD is not going to be happening. Yes, we are going to abort. And assuming that you can actually clean up this amazing bowel prep, you will probably convert this to an EMR just because you really don't want to risk an ESD here. So this is a lecture for women in endoscopy, and so the analogy I like to give is that EMR has existed since the early days of colonoscopy in the 1970s. So EMR is the mom here, and ESD came in the 1990s, and so ESD is the child. And so, I want to talk to you guys a little bit about mothers and the special role that mothers play, and what happens when a child fails. Mommy comes to the rescue, and so EMR always comes to the rescue. That's why you got to know about EMR and how to perform the perfect EMR. And so there have been a lot of iterations and serial refinements in technique, stiff snares, high viscosity injections, management of bleeding, management of recurrence, better closure devices, all sorts of technical variations, hot, cold, band, cap, underwater, tip-in, pre-cut. But fundamentally, the technique and principles of EMR have not really changed in about 50 years. And EMR is alive and well in 2024 because ESD and full thickness resection are not always technically possible. And so you still need, no matter how good you are, you still need solid fundamental skills in EMR. So, what do we consider the cutting edge of EMR? Raju is the cutting edge of the perfect EMR. And if you guys don't know who Raju is, you may want to look at his YouTube channel. He is internationally renowned master of YouTube, and he is my senior colleague at MD Anderson Cancer Center. And he published his own experience in EMR of lesions greater than 20 millimeters, published in the phenomenal journal Endoscopy International Open in 2020. And Raju has basically, for many years, followed a standardized recipe for the perfect EMR. And I've basically been watching him for the last 6 years that I've been at MD Anderson. He basically uses a cap-fitted colonoscope, injects saline, resects with a snare, always the exact same Irby settings, forceps avulsion for small areas that he cannot remove with a snare, APCs the margins, closes with clips, and repeats their colonoscopy at 6 and 18 months. The Raju EMR, he published this in 2020. He had 246 patients with LSTs greater than 20 millimeters in size. So average or median size was 35 millimeters. 70% piecemeal resection, median time of 60 minutes. Out of 246 patients, he only had 8 bleeds, 1 perf, 2 hospitalizations, no surgeries, no deaths. 4.5% recurrence. Guys, let's compare this. Michael Burke, 1,000 patients in gut, 2015, had 16% recurrence. Guys, Heikel Pohl, Doug Rex, 928 patients, gastro 2020, had 17% recurrence. Guys, Doug Rex, 1,700 patients, gastro 2021, 15% recurrence. I rest my case. Why is this published in Endoscopy International Opens beyond me? But clearly, he's doing something right. So I've observed him as my colleague for the last 6 years, and from an ESD perspective, I've basically tried to replicate what he does with EMR. So what constitutes a perfect EMR? So it boils down to several things. Number one, you got to select the proper lesion. So proper lesion selection for EMR should be those that have low likelihood for invasive cancer, SSAs, homogeneous type LSTGs. So in other words, the sort of uniformly bumpy type lesions, the flat elevated type. And even with ESD, I will tell you that most lesions can be removed with EMR. You just have to understand that there's a risk for, I guess, a 4.5% chance of recurrence if you're really good. And there's a risk for incomplete and piecemeal resection and malignancy. But that you have to realize that that is more of a failure of optical diagnosis rather than a failure of your EMR. And still, one thing that you guys have to remember is even in 2024, people get caught up in ESD and full thickness resection, but realize that when ESD or full thickness resection are not available, EMR is still better than surgery, and it's still better than doing absolutely nothing. So you got to examine the lesion, right? So this is an LST. This is a homogeneous type. Everything is kind of uniformly bumpy. It's about 4 centimeters in size. I don't see any features that are concerning for malignancy here. I don't see any major dominant nodules. I don't see any areas of pseudodepression. This all looks like an EMR case. So the plan here is EMR. So, second step. How are you going to plan this resection? So it actually is very important to think about strategy. And it comes down to not just the strategy of how you're going to do the EMR, but even before you do the EMR. Think about anesthesia. You may want to think about putting patients to sleep under general anesthesia for EMRs. Why? Because do you really want the patient to be breathing heavily? Do you really want the patient to be coughing? Do you want any sort of problems with obstructive sleep apnea? So maybe it's a good idea to consider general anesthesia for big EMRs. Consider the location and the size of the lesion as well, right? If you have an EMR in the rectum, you could probably get away with propofol. If you have a big EMR in the cecum, you may want to think about general. And consider, do you need to reposition the patient? So in other words, if you have a patient who's 120 pounds, whose lesion is directly under the gravity, then you may need to reposition the patient. On the other hand, if you have a patient who's 450 pounds, you may not be able to reposition the patient. And you may want to think about anesthesia strategy here in terms of how do you want to sedate the patient. Second thing is scope stability. Can you achieve a straight scope position? You have to be straight in order to conduct a perfect EMR. You cannot be looped here. If you're looped here, all your movements are going to be paradoxical. One of my mentors used to abort cases purely because you cannot get the scope into a straight position. And I really respect that because it has to do with safety and it has to do with setting yourself up for success. Do you use a pediatric or adult colonoscope? Interestingly, there's a lot of variation there. I personally use an adult colonoscope, so does Raju. Some people use a pediatric or what's called a hybrid colonoscope if you're using Fuji scopes. Just realize that there's some variability here, but the fundamental here is you have to be stable. Next, you want to decide on a resection strategy. Are you going to do a conventional hot EMR? Or are you going to do something a little bit different, like a cold EMR or an underwater EMR? Those concepts are beyond the scope of this lecture. But the most important point here is to realize that do not start the resection unless you're confident that you're going to finish, because it is better to refer to an expert colleague rather than starting and failing and causing a major fibrotic headache down the road. So, what about this thing? Well, it's a healthy patient, so I think propofol is completely reasonable. I think this was a 45-year-old patient, average BMI. What about the scope? Well, adult colonoscope for stability. Use a distal attachment cap in order to be able to go across the folds. Have a nice and straight colonoscope. I think I had the scope at 75 centimeters from the anal verge here in the cecum. Strategy, a standard hot EMR. And then what about injection? So I put the first injection here. And the reason why I put the first injection here is because you want to be able to lift the entire polyp towards you. So you actually, this may sound counterintuitive, but you actually want to inject the hardest region first because you want to make the most difficult to access, most difficult to visualize region easier to access and easier to. So then I put my second injection there. And so the reason why I put my second injection there is because now that you have your first injection, you can lead off of that corner of the first injection to basically add your second one. So then you add your third injection there. And again, you're going off of the edge of the second in order to plan your third injection. Last but not least, go for the easy one up top. And by then you should have everything already lifted and you should be ready to go. So with regards to injection, dynamic injection plays a large role in the overall success of the procedure. You don't want to go too deep because if you go too deep, you may not be injecting the submucosa at all. You might be injecting outside of the colon altogether, or might be intramuscular, or might be intra or even retroperitoneal. You might still get what you think is a lift, but it will end up not being a lift because if you inject the retroperitoneum, that will also give you the impression of lifting. You also don't want to inject too superficial because if you go too superficial, yes, you'll get a lift as well, but it'll cause a huge intramucosal hematoma. And the last thing you want is to have blood in the operative field. Now, realize that you are committed when you decide to inject the lesion. And that is especially true if you're injecting a high viscosity agent. In other words, a non-saline agent. So do not inject high viscosity agents just to see if it will lift. So this is what's dynamic injection. So again, injection number one. So getting just into submucosa, right, and getting the lesion to face you. Injection number two, again, pushing it down with a cap and then injecting here. So using the corner of the first injection to do the second one. Third one right there again, using the corner of the second one to get your third injection going. And then last but not least, moving the lesion forward and doing a fourth injection here. At this point, this LST, by the way, starts looking more and more like a mixed type LST rather than a homogeneous type. That's just kind of a bit of an aside in terms of optical diagnosis here, because you have a Paris 1S right there with a dominant nodule, and then you have the Paris 2A next to it with all the uniformly bumpy stuff. And you want to make sure that you have enough of a lift here as well. And there you have it. And so now you are ready for EMR. So do not perform a test injection just to see if it will lift. So this came out of one of my own colleagues. This was a 2.5 centimeter polyp, a Paris 2A. And this was injected with 43 milliliters of Everlift just to see if it would lift. And then after lifting the lesion, the endoscopist decided, I don't know, I think this is a little bit bigger than what I was set out to do, so I think I'm gonna. Well, 2 months later, this patient came to me for an ESD, and you know, it's not that the lesion grew. The lesion did not grow. It's just that the lift never went away. This is what it looked like in the submucosa. This was an aborted ESD. This was one of very few ESDs that I've ever had to abort because it was simply impossible to resect. So let's talk about snare strategy, right? So now that we have a lesion that is fully lifted, how do you decide where you're going to start the EMR? So you want to find a stable position, preferably near a 6 o'clock position, and you want to go after that dominant nodule first. Remember how with the lesion I showed you, initially we thought it was an LST homogeneous type, and then as we started injecting, we realized that, wait a minute, there's a dominant nodule, there's an LST mixed type with a dominant nodule. You want to take the dominant nodule first, and you want to take that nodule on block, because if there's going to be any more advanced pathology, whether it be high-grade dysplasia or early malignancy, chances are it's going to be within that dominant nodule. Now, what if there's central fibrosis, like in these pictures here? Well, if there's central fibrosis, you're more likely to result in a piecemeal resection. But, you know, all the techs that I work with, they all know that my best friend is not my ESD knife. My best friend is a 10 millimeter snare. Switch to a smaller snare, because with a smaller snare, you can grab more effectively. Sometimes we are also forced to go all the way down to hot forceps avulsion technique, and that would be in cases where there's a small amount of residual polyp that's just too small for your 10 millimeter snare to even capture. At that point, you can go down to a hot forceps for avulsion. Last but not least, there's a more advanced maneuver known as tip-in EMR, where you can basically use the tip of the snare to make a tiny little pre-cut and use that to anchor the rest of your snare. So, first piece, take out that dominant nodule. So do not let that dominant nodule get away with it. Go for it first. And get that thing on block. So this was something that was taught to me by one of my mentors when I was in GI training. Jiggle the snare. I always jiggle. And the reason why you jiggle the snare is basically sometimes you might get just a little bit too much. And the last thing you want to do is to have EMR become a stressful experience by getting a little too much. So jiggle the snare. And when you jiggle the snare, what you're doing is you're basically giving the muscularis propria one last opportunity to run away. So you're giving that MP a last opportunity to escape you. And oh, look at that. So we can even temporarily cauterize vessels using the tip of the snare. One additional point that I skipped over here was called planting the flag. So one way to always reliably make sure you get the snare in the right place is what's called plant the flag. So you want to plant the base of the snare directly at the base, at the bottom of the submucosa, and then close over it, because that avoids a situation where your snare slides over the lesion. So you want to plant the flag, plant the base right at the, plant the base of the snare right at the base of your resection, and then close the snare from there. That way you capture as much tissue as you want it to. What about really fibrotic stuff? So fibrotic stuff, you really want to plant the base here. So this is a recurrent polyp. This is over a fibrotic site. You can see here, this looks like This does not look very promising. It really does not look like it wants to cut here. So it's kind of sort of sliding over, right? But see, you know, I couldn't capture this side on the right? You see that? So one way to do it would be to pre-cut this. So this is kind of like a borrowed technique out of the ESD playbook here. You're basically, what you're doing is you're basically giving yourself a new edge for your snare to wrap around, right? So you're basically creating the path for the snare to grab. In case you're wondering, this video is not sped up. But now you see that now that we've cut a ring, you can actually plant your snare around it. And now when you close, you can actually get the entire thing. Success! You gotta finish the job. So this is one of those things where I always tell my fellow, don't get lazy. Take an adequate margin because your first shot is your best shot. And sometimes, and this is a bit more advanced, this is again borrowing out of the ESD playbook, sometimes a pre-cut EMR, which is more of an advanced maneuver where you use an ESD knife to cut circumferential margin, and then you EMR inside of the circumferential margin. Sometimes that can help guarantee you margins. But you have to be able to carefully look at a lesion and carefully make an optical diagnosis. This picture that you see here is what is known as a skirt lesion. So a skirt lesion was first described in 2017, but people have been noticing this phenomenon for far, far longer than that. Basically what it is at the edge of a polyp, there is an area that is less visible, but it's still polyp. So if you look at where I have the arrows here, that is the true border of the lesion that you see in this picture. And the presence of a skirt lesion is a predictor for local recurrence because if you are likely to miss it, you will likely have recurrence. And so it's important that when you're doing EMR that you first properly examine the lesion and make sure you actually understand where the borders truly are, not where you think the borders are. Make sure you get really close to the mucosa, carefully examine the surface features of the lesion you're dealing with so that you really understand where is the actual border of the lesion. Don't miss the skirt lesion. And so now going back to our polyp here, our cecal polyp. So I've taken two big pieces with a big snare, right? I took the dominant nodule out on block. So now I got smaller pieces, so I'm going to switch to my trusty 10 millimeter snare here. There we go. Piece 3. And then we only got this other one here. And we got piece 4. Oh, looks like it's kind of going over here. So suction down a little bit and try again. There you go. And here we have piece number 4. And that looks good. So you want to clean up the vessels. There are several ways that you can decrease the risk for post-polypectomy bleeding. So again, borrowing from the ESD playbook, I use hemostatic forceps. So I use coagraspers to basically close up vessels. Use a soft coagulation current, you buzz all the vessels. Super useful that way. If you do not have hemostatic forceps, you can actually use the tip of the snare under soft coagulation and achieve the exact same effect. Another way to do this is there's been a lot of interest in topicals lately. So there's stuff like Next Powder, which is a hemostatic powder, and there's also stuff like PureStat, which is a self-assembling peptide gel. Those are all on the market and marketed to be used for decreasing the risk of post-polypectomy bleeding. Finally, there's defect closure. So I routinely close all of my EMR defects. I do not close all my ESD ones, and that's a bit controversial, but all my EMR defects I close because with EMR, there's a possibility of blood vessels in the submucosa that are completely hidden and that may bleed later on. So cleaning up the vessels here. So you saw I already took care of the active bleeder with the tip of the snare earlier. So now we're basically just going to use a hemostatic forceps and basically clean up the vessels. As a bit of a bonus, people have used APC to clean up the margins like Raju to decrease the risk of recurrence. If you have a coagulation forceps, you can actually use soft coagulation to achieve the same effect. And so, yes, we talk about cleaning up the margins here. So this is the final picture from the resection, actually, before we went ahead and closed up shop. But there are some strategies that you can use to decrease the risk of recurrence. So you can take an adequate resection margin, biopsy lateral and deep margins if you're really unsure. You can buzz the edges with soft coagulation using the snare tip. You can also buzz everything with hemostatic forceps, or you can use APC, as Raju originally discussed. So here we go. So I already have hemostatic forceps out because I've been buzzing vessels here. So I'm going to basically use the same hemostatic forceps, and I'm going to go ahead and take care of all my margins as well. And people ask, well, how long do you cut for, or how long do you buzz for, rather? So you buzz until it looks like a toasted marshmallow, if you will. And what about the defect itself? So in EMR, it makes sense to close defects. And the reason is because you can have hidden vessels deep within the submucosa or around the resection edges. If you end up hitting muscle for any reason during EMR, that definitely needs to be closed. Otherwise, you run the risk of perforation, whether it's during or delayed. And so here, this is with clips. This is actually with Mantis. So this is using Mantis clips to basically close the EMR defect. I'm basically dragging one side to the other. First clip here. There's a little bit of a strategy to clip closure. You want to start from one side and go for the other. It's what's called a zipper closure. You don't want to just like go for the middle first. You want to start on one side, because by starting on one side, you're making the rest of the defect smaller, right? You can see here, I've basically, by strategically closing down, I've made the rest of the defect smaller. Here there's a slight gap in the middle, so I'm using clips to basically close up the gap here as well. And by the time I'm done, I think I've placed like 8 or 9 clips here with everything perfectly lined up, and the defect is completely closed in there. So post-procedure. So recovery is something important to talk about as well. So it's not, it doesn't end when you finish the EMR. So afterwards, there's some stuff to consider as well. So for non-complicated resections, I usually will restrict patients' diets for a couple of days. Raju has a protocol where it's clear liquids for the first day, and then full liquids for day 2 and day 3, and then a soft solid diet for day 4 and day 5, and go back to a regular diet on day 6. You can tweak this a little bit, but I generally speaking will do something similar where I'll have patients on a liquid diet for about 2 to 3 days. I do like a clear liquid diet for the first 24 hours because that makes life a lot easier if they come back bleeding and you're talking to your anesthesiologist about rescoping them. I typically will hold anticoagulation for 2 to 3 days if it's safe to do so. So obviously, make sure you get cardiac clearance before you start embarking on these types of procedures, because the last thing you want to do is to hold their anticoagulation and to get a cardiovascular event. The last thing here I want to make sure that you understand is, I don't like doing EMRs on Fridays. And that just has to do with the fact that most bleeds or delayed perfs will happen within the first 24 to 48 hours. So doing EMRs on Fridays, personally, I think, especially when you're young and just starting, I don't think that's a good policy to do. Do yourself a favor, do your EMRs and ESDs or whatever major procedures that you do them early in the week. For complicated stuff like major bleeds, concern for perforation, you may want to think about an elective hospital admission, maybe some bowel rest, plus or minus antibiotics. Now, what about anesthesia, right? So I never really learned these rules until I started doing ESD and EMR because, these you typically don't. This is typically not relevant to you. But if you're doing a lot of EMR, this does become relevant. SEDs for DVT prophylaxis, if your procedure is going to be predicted to be greater than 2 hours. We also use a bear hugger, so temperature management if the procedure is expected to be over 3 hours. And then some sort of urine output management, like Foley catheter or straight catheterization, if the procedure is going to be more than 4 hours. I always call patients myself. And this is something that I've done ever since I was a fellow. I still do it to this day. This is kind of my trademark. I call patients myself with pathology results because it allows you to see if they recovered well. And it just kind of gives a personal touch to the medical care that you're giving. I will tell you that patients absolutely, absolutely appreciate a personal phone call with their pathology results. And then I always follow up piecemeal EMRs with a colonoscopy in 6 months for all my piecemeal EMR resections. Wait a minute, did you forget something? Did you forget something? So you finish the EMR and you come back. Wait a minute here. Did you forget something? So this is real life. So, I did not know that I was going to run into another polyp. I did not know I was going to perform a second perfect EMR here. I did not know that during the rest of this colonoscopy, I would be coming back and finding another 6 adenomas. Yes, this patient had 6 additional adenomas that were left behind or missed altogether. So yes, synchronous lesions. It's something that's very common. Don't forget this. If there's anything that you take away from this lecture, and I know I've run over time here, I'm so sorry to the moderators that I've run over time, but this is super important that there is a 84 to 89% chance of synchronous lesions when you deal with patients with polyps greater than 20 millimeters in size. Do not ignore synchronous lesions. Remove them if it's feasible. If it's not feasible, like if you've thrown 3 hours at an EMR in the cecum, okay, I get it. The patient's cecum can only handle so much and the patient can only handle so much. Fine, bring the patient back, but bring them back soon. So within 3 to 6 months. But I always, always repeat the scope myself, or you make sure you have a really reliable partner because you got to remember this. After this lecture, you are going to become the expert performing the perfect EMR. So if you are missing polyps, or worse yet, if you are having an interval cancer, that makes you look bad. So I always scope the patients myself. I know that a lot of my colleagues around the country do not agree with this statement. I do it myself because I think it's part of the package. When you are referred patients for EMR, do the patient a favor and make sure you actually clear their entire colon. So the pearls here. The perfect EMR. Well, you need perfect pre-procedure diagnosis. Is the indication correct? Is the lesion indicated for EMR? You need a perfect resection strategy. Can I finish the job? It does not have to be on block. It really does not, but it does need to be complete and it needs to be curative. And you need to ensure a satisfactory post-procedure recovery and adequate follow-up because EMR doesn't finish when the scope is pulled out. In conclusion, EMR does not necessarily treat the same lesions as ESD and FTR. It's complementary to it. It's parts of the same toolkit for endoscopic resection. Your perfect EMR technique is mandatory if you want to go further and learn additional techniques, because when you perform these additional techniques, you will still need to draw on the principles of EMR in order to finish properly. And you know what? There is no shame in admitting that EMR is sometimes the best you can do, and that is perfectly okay. Make sure you do it well because sometimes the patient is simply not a candidate for anything else and not even for surgical resection. So EMR is the best you got, and EMR, quite frankly, is good enough. Mom's rule, don't forget dad too. So EMR, ESD. Thank you very much, everyone, for your time. Have a great rest of your day.